Coming of Age is coming up next. I'm your host, Emily Echeverria. First today, we're talking with Andrews Institute Total Joint Specialist, Dr. Wesley Mays, about hip and knee replacement procedures. We'll discuss how to know when it's time to talk to your doctor about joint issues and what the preparation and recovery can look like for these types of surgery. We'll also talk about the issues and challenges facing the homeless population in our community and an organization that is working to help. Lastly, we'll be speaking with author, speaker, and advocate Dr. Betsy Smith about the work of patient advocacy. Stay with us. Coming of Age starts right now. As we age, staying active in life and involved in the community can become a challenge. But with Council on Aging of West Florida's wide range of home-based services, you remain healthy, independent, and engaged. From Meals on Wheels and respite care to senior dining sites and the retreat, you'll find the support and connection that you need to age well. Aging looks different for everyone, and we're here to help you meet your needs and thrive while maintaining what makes you, you. We've been in the community since 1972, advocating for elders and supporting those who care for our parents and grandparents. Now, join us as we discuss the age-related issues that matter to you. Hip and knee replacements are becoming more commonplace as our population ages. Here to talk to us today about what options are available for hip and knee replacements is Dr. Wesley Mays, an orthopedic surgeon and total joint specialist at the Andrews Institute for Orthopedics and Sports Medicine. Thank you, Dr. Mays, for being with us today. So what is total hip or knee replacement?
So with a total hip replacement, we're essentially just recreating the ball and socket anatomy of a normal hip. So we replace the whole head ball from the normal hip. And then with a total knee, we are essentially just resurfacing the ends of the bone with metal and then using a medical grade plastic on the inside to recreate some of the meniscus, cartilage, that sort of things that are worn out from arthritis.
What's the difference in total and partial knee replacement?
So a total knee replacement is when we have a knee that is so worn out on both sides of the knee, the meniscus, ACL, where we have to go in and resurface the whole end of the thigh bone and the top of the tibia bone. The difference with a partial knee replacement is we just pick either the inside or the outside to resurface the ends of the bones with the plastic disc. And you get to keep things like your ACL, the whole outside part of the knee in terms of the meniscus. It's only half the surgery of a total knee. So it's a quicker recovery. It's a more normal feeling knee to you, since most of the knee is remaining your normal anatomy.
What causes the need for this procedure?
So with any joint replacement, the need for those is people who have gotten to the point where the articular cartilage, which covers the ends of the bone and should look nice and shiny and smooth, ends up rubbing off to where it is more kind of bone-on-bone arthritis, and the cartilage cap on the ends of the bone is gone, and we're left with just kind of bone-on-bone sandpaper rubbing on each other.
How does someone know when it's time to come see you to talk about whether this procedure is right for them?
So a lot of times people will come into us and say, they've noticed that they can't do their just kind of normal activities, getting out in the yard, gardening, going on walks, or people have noticed that they have started to limp more, can't quite keep up as much as you used to, with other, when you're out shopping or walking, and you've noticed that, people are, way far ahead of you and you can't, keep up and that sort of thing, or kind of waking you up at night, and, other things affecting your kind of normal daily routine.
What is the prep work for a patient that decides to get this procedure?
So obviously, first, we like to try things to avoid the surgery. We're surgeons, so we're always happy to operate on people. But, if we can get you feeling better and feeling, more normal and, back to your normal activities, with either medicines like nonsteroidal anti-inflammatories, either prescription strength or over the counter, or with intra-articular injections. There's a couple different kinds from a steroid or a gel injection standpoint. Those are things we usually like to try and at least try before a joint replacement surgery, because obviously we can always do the surgery, but if you have the surgery and you could have gotten better with just a medicine or a gel, obviously those are lower risk than the surgery itself.
Are there factors that would prohibit someone from being a good candidate for this procedure?
So there are, we've noticed in the last several years, the whole term pre-optimization before surgery has become, kind of a more hot topic. So, if we've got a patient with diabetes, making sure that's well controlled. There are higher risks for infection, a bigger surgery, bigger dissection in patients that have BMIs over 40. So we work closely with the weight loss clinic at Baptist Hospital, trying to, make sure that, number one, patients are, doing, what they can to be as good a candidate for surgery, and that they, are as optimized as they can so that the recovery after the surgery goes smoothly.
When someone has this procedure, how long can they expect to be in the hospital?
The majority of the patients can either go home the same day, so you get up and work with physical therapy and go home the same day, or spend the night, go home the next day.
What does recovery look like? Are they ever good as new?
So the goal of any joint replacement is to make it feel like you forget your joint. The forgotten joint is kind of the goal. The hip replacements usually bounce back a little bit easier. It's, essentially just recreating the ball and socket. So that usually, does pretty well from easier to bounce back from. The knee replacements do take, a month to 2 months to kind of get things moving again. There's more pain and swelling for the first 2 weeks, 3 weeks with a knee replacement. That's, a lot of icing, a lot of elevating. But that, the goal is being as good as new. Obviously they're metal and plastic joints, so it's not going to feel like patients were when they were, 15, 20 years old, but getting them back to reasonable activities like going on walks, playing tennis, playing golf, all those things are, definitely within reason.
How long before they can expect to be finished with rehab?
So typically about 6 to 8 weeks. For hip replacements, it's a little bit quicker. It's more, just kind of getting your gait back to normal, because a lot of times there's a lot of limping involved preoperatively. And then with the knee replacements, I usually tell my patients anywhere from 5 to 12 weeks. And so we work really closely with either the home health therapist or, a lot of the therapists with Andrews or other places in town. So, they've all kind of got our contact, and whenever they, essentially whenever we feel like you are ready they feel like you're done with physical therapy, we let them decide for the most part.
What's the best way for a potential patient to reach out if they want to come see you?
So the Baptist Hospital has an easy schedule. I think there's billboards around town in terms of, kind of clicking on that link. And then the AndrewsInstitute.com is a good way to find more information. Our phone numbers are 850-437 area code 850-437-8592.
Thank you so much, Dr. Mays. Next up, we're discussing the challenges facing homeless individuals and families in our area and how one organization is working toward mitigating this complicated issue.
Transform your bathtub into a walk-in shower with TubCut.
It's the greatest relief in the world, being able to feel safe in the bathroom again.
TubCut installs in 1 day, is 100% reversible, and has a lifetime factory warranty.
I had shopped around because money is an issue, and I found that the TubCut was the most affordable choice.
Get affordable, safe, and easy step-through access to your shower.
Call TubCut at 850-529-7601. The Reesburg Institute, Pensacola's ear, nose, throat, and voice center. We welcome you to visit us at our convenient Davis Highway location in Pensacola. At the Reesburg Institute, we offer the most advanced treatment available in a calm, stress-free environment. Since 2014, we've performed over 1,000 cases in office of balloon sinus surgery, as well as septoplasty and nasal procedures using oral sedation. The in-office procedures result in a faster healing time. Visit us and feel the difference. The Beacon at Gulf Breeze offers the finest senior living community in the area. We are here for your loved ones who need assisted living and advanced memory care services. Seniors will feel right at home with studio, one-bedroom apartments, a large dining area, a beautiful landscape courtyard, and even a salon. With professional staff and one-on-one care, your loved ones are our top priority. Welcome to the Beacon at Gulf Breeze. Welcome home.
The issue of homelessness is multifaceted, and so too must be the approaches to addressing it. Opening Doors Northwest Florida is an organization that has been here for 30 years. They've been working in Escambia and Santa Rosa counties to raise awareness about the true nature of homelessness, fund programs that actually help, and break the cycle of homelessness. We're speaking to Executive Director John Johnson about what Opening Doors Northwest Florida does and how others can get involved. Thank you for joining us today.
I'm glad to be here, Emily.
So first off, tell me a bit about the mission of Opening Doors Northwest Florida.
We want to give people a hand up, not a handout, and we want to reach, respond, restore. Reach, respond, restore.
What does that mean?
Well, it talks about, the idea is to go to people where they're at. So how do we reach them? Many of them have mobility issues and they can't get to our organization. So we have a street outreach program that actually goes to them. So once we reach them, respond to whatever issues that they're facing. And so many of them have ID issues, birth certificates, housing, food, deficits, those kinds of things, and even healthcare and connecting them with mental health services.
Okay.
And then that's the respond part. So once we reach them, we respond to them. We want to make sure that they have the tools that they need to elevate them out of homelessness.
And what are some of the greatest challenges in assisting the homeless population in our community that you're seeing?
I would say probably hands down identifying affordable housing, and it's a list of about 20 issues, but that one is probably at the very top. Is once we respond to them, where do we place them? And what is sustainable for them? Many of them are on limited fixed incomes, receiving $794 a month. That's not hardly enough to pay rent, utilities, especially with the market prices of today.
And what are some of the issues particularly facing elderly members of the homeless community?
Same thing. So we've seen a spike in Florida power, to say the least. And so when you're getting only $794 and you're probably in a subsidized unit, most of your income goes towards the utilities. And so if there's any kind of hike in utility costs or even rental costs, then that person or that individual, that elderly person is going to be very challenged with continuing to pay the cost. Many of the programs out there, Emily, are one time. So when you come and you seek assistance, they help you with that past month's rent. But what about the next month and the next month and the next month?
And you mentioned a little bit about the FPL rates. I know you offer some rent or utilities assistance in some cases.
Yes.
Are you hearing from the community members about the higher power bills, and are you able to assist with that?
Okay, complaints, absolutely, all the time, and even at nights and on weekends, we get complaints. So yes, we're able to help with the utility costs. Some of the funding we receive is flow-through dollars. We partner with other agencies to help shoulder the burden of the heavy volume of calls that we're getting. Agencies like 90 Works, agencies like Reentry Program and Catholic Social Services are the agencies that we partner with to help us meet the burdens of all the calls that we're getting.
I know you worked recently on the relocation of the folks at the I-110 encampment, and the city has started looking at the encampment near the 17th Avenue graffiti bridge. Are you working with the people there, and what steps are you taking with these people to assist in those situations?
So yes, our role is often to be an indirect partner as well as a direct partner. And so when I see loops or gaps in services that's not being addressed, we'll go address it directly. And we're partnering with REAP to address the folks at the Graffiti Bridge in the same way we did at the I-10 bridge. But there are other locations in the community, Emily, unfortunately, where there are congregate, unsheltered people living that have a huge need.
Mm-hmm. I'm sure. Well, how can people get involved or support the mission of Opening Doors?
So there are a couple of ways. We have a task force that is addressing transportation, food, case management, mental health, housing. So people can join that. They can donate directly to us. And one thing about donations we receive, 100% goes back to the client. We don't pay any admin or any costs for operations. 100% goes back to meeting the needs for the clients.
Thank you so much for being with us and giving us this information today.
Thank you, Emily. Thank you for having me. It's been my pleasure to be here.
Stay with us as we discuss the topic of effective patient advocacy next.
Since 1989, TLC Caregivers has been providing the special help people need to stay independent in their own homes. TLC is an employer of choice in the home care market. Our employees are screened with level 2 background screens, drug-free, and have caregiving experience. If you have time, enjoy people, and are interested in joining us, go to tlccaregivers.com to learn more about becoming a TLC caregiver or visit us in Cordova Square.
For more than 25 years, the potential for health improvement is seen with each patient that walks through our doors. Healthcare decisions don't have to be confusing. Make Island Doctors your medical practice.
My husband and I have been coming to Island Doctors for approximately 10 years, and we have been very happy with them, and we trust them.
Call us today and schedule a tour of one of our locations near you and take a look at our Best Wellness program, and welcome home.
When cancer tries to take you away from the things that matter most, Baptist Cancer Institute offers caring physicians and the most innovative treatment options. With convenient locations and a wide array of support programs and services, we're here to help you during the most difficult of times. As a member of the Mayo Clinic Care Network, we're bringing even more innovative cancer care to our community right here at home. When you need cancer care, we'll be there.
We all know that navigating the healthcare system after a challenging diagnosis for ourselves or a loved one can be difficult and scary, and it's often something that we have to tackle unexpectedly. That's where a patient advocate comes in. We're talking with author, speaker, and leadership coach, Dr. Betsy Smith, who quite literally wrote the book on this topic. Her book, The Patient Advocacy Handbook, tackles this topic in depth, and she's sharing with us today some of the lessons she learned on her own journey as a patient advocate. Thank you for being with us today.
Well, thank you for the invitation. I'm excited to talk with you and tell the world about my book.
Awesome.
Yeah.
Tell me a bit about your personal journey into the world of patient advocacy.
My husband, after Hurricane Ivan, we moved up to North Carolina and lived there 10 years. And my husband was diagnosed with bone marrow cancer in 2014. And I shall never forget what he said to the hematologist when he heard those words, "No one wants to hear, you have cancer." His response was, "How can a man who feels so good be so sick?" So we were in the healthcare system for 4 years. I saw him get some good care, and I saw him get atrocious care. And this one day, the research nurse says, the next test we do has to begin in 30 minutes. And I went to the waiting room of this lab. And it's 30 minutes, and there's my husband, Jack, in a wheelchair, in a corner, asleep. I shrieked, "What's my husband doing out here?" And a technician came out and he said, "Well, we didn't know he was here." And I said, "Well, you know now. Go take care of him." And that's when I learned I had to stay on my toes. And people weren't malicious. They weren't evil. They weren't mean. They're overworked. And they're human beings.
At the Council on Aging, we deal a lot with the concept of being a caregiver for an aging loved one. And what are the distinctions between being a caregiver and being a patient advocate?
You can be both.
Mm-hmm.
But my definition of a patient advocate is the person who will stand up for the patient, the person who will ask for another doctor, the person who will say, "What does that mean to me? Can you explain that to me in language I understand?" A person who knows to call the charge nurse. I interviewed several people for the book, and this one gentleman, very successful professional businessman, told me the story of his 80-something-year-old mother was in the hospital. He was in the room with her. And she said to the nurse, "I'm having a heart attack." And the nurse said, "Oh, it's just indigestion." And the woman died with her son sitting in the room. And I said, "You didn't ask for a charge nurse. You didn't ask for the doctor on call. You didn't ask for a social worker. You didn't ask for an advocate." And he said, "I didn't know. I didn't know who to ask for."
Mm-hmm. What would be the first piece of advice you'd give to someone who has received that diagnosis for themselves or a loved one and is beginning to take on that role of patient advocate?
Research, research, research. Research the disease, research the doctor. For every disease, Emily, there's a nonprofit organization, like the Council on Aging.
Mm-hmm.
And if you buy my book, the Patient Advocacy Handbook, there's links to resources that you can get. And one of them is, I don't know, the worldwide list of nonprofits.
Mm-hmm.
So you can just go, you don't have to start searching, you just go to that link and find the nonprofit that you're interested in.
What tips would you give a potential patient advocate about the daunting task of navigating the healthcare system? I know it can be really bureaucratic and sometimes inscrutable.
It is. My first piece of advice is think about how you're going to take care of yourself. Now, I'm going to say this, and I did not do it, but I used to go to the gym 3 times a week. And first thing in the morning, and then Jack got sick, and he got sicker, and he got sicker. And then there wasn't any time for Betsy. So anything you can do to relax those shoulders, go outside, make a friend with a valet and have a conversation outside.
What advice do you have for having the tough conversations that might be necessary for a difficult prognosis or end-of-life care?
Gear up. My phrase is be ready, be bold, and be heard. And by that I mean, if you don't understand something, ask the doctor to explain it in words that you can understand. If you don't know what meds they're giving your patient, ask what that's doing. I remember one time a nurse was going to give Jack an Ambien, and it made him crazy. And about the time she was going to put it in the medicine cup, I said, "What is that?" And she said, "Well, it's Ambien." "Don't give him that. Don't give him that." Now, I wasn't mad at the nurse. I was just mad. And so I manifested my fear with anger.
Mm-hmm.
Yeah. The other story I want to tell you is, for reasons, I have family in Texas, way out in West Texas. And my 8-year-old third cousin beat leukemia. Jack had met her while they were both going through treatment. So he says to me, "We're going to her party." And I said, "Jack, we can't get in a plane." We went to the party. Jack got sick, got pneumonia, went to this little tiny town's hospital. One thing they did was put Jack's name label on somebody else's blood vial. Wow. And thank God the nurse caught the discrepancy in the blood counts from midnight to 6 o'clock in the morning. One hospitalist, the doctor that just works in the hospital, told me I could take him home. He would release him to go home in an ambulance. It's a 37-hour drive from outer BFE, Texas, back to North Carolina. So I said, no, we're not doing that. So then he comes in, he said, I'll release him to fly commercial. And I said, oh, we can't get on a plane. His 4 adult children were there. One from Canada, one from Wisconsin, one from Virginia, and one from North Carolina, out in this little tiny town. So after the doctor said I could fly him home commercially, I looked at his kids and I said, I'll be back. And I found the hospital CEO. And I had a hard conversation with that gentleman. The theme was, I want my husband back in North Carolina tomorrow. And he said, are you threatening me? And I said, take it how you want. You make sure it's worth it to you in this hospital, not to get my husband back to North Carolina tomorrow. The next day, we were on a Learjet going to North Carolina, compliments of the hospital.
Wow, and that's effective patient advocacy.
And I tell that story so people, hopefully, will be empowered. As a matter of fact, one of my LinkedIn posts is, how far is too far up the hierarchy? Mm-hmm. There is none.
Well, thank you so much for being here and sharing your story and information about your book.
And the book is available on Amazon.
Gotcha.
And I hope that people will buy it and learn from it and write a review on Amazon.
Excellent. Until next time, enjoy life. You've earned it.